Thanks, Dustin. Next, we've got Dr. VK Sharma, who's going to talk about other aspects of reflux testing, past, present, and future, including mucosal impedance. VK, thanks.
Thank you. Okay. Well, I want to thank the organizing committee for the invitation. These are my disclosures and my 2 cents about conflict of interest. So the organizing committee came back to me and they said they went through my disclosures and they found they were too numerous to count. It felt like dirty urine analysis. But Felice said that we did find a talk that you can give. You can talk about reflux testing, but you don't have any conflict because you haven't done much in that field. And I said, are you kidding me? And she goes, this is the easiest talk of this whole conference. You can't screw it up. And I said, try me. So I have no confirmation bias out here. So I can, and this is now my work, so I can crap all over it. So I'm going to first start with the definition. You're going to see it come over and over again. And I'm going to bring a practicing gastroenterologist perspective. So the Montreal definition and classification of GERD is condition which develops when reflux of gastric content causes troublesome symptoms. If I took it to my clinic tomorrow, any symptom above the belly button will fit this classification. The discriminating factor I would say here is reflux of gastric content, and I can bet to you by history you cannot tell that heartburn patient is having is because of reflux of gastric content or something else, or that chest pain, or even regurgitation, which we think is a reflux of gastric content. Historically, we cannot, or by history, we can't be sure that that's what's causing it. So then I thought through what could be a patient that will fit this definition, and somebody showed me on their iPhone that they had thrown up bile and they were bothered by that symptom, that would fit the Montreal definition. And we all know that's not acid reflux. So the problem is, and we have 400 people out here talking about this disease, that this is a very complex disease. And if I could find a picture on Google Photos with more blind men, I can put it on the slide and give each of them one mechanism of action which is causing acid reflux. So we're trying to define a disease which is this complex by a definition that's that simple. And I think we are doing a great disservice to both the clinicians, the researcher, and our patients. So now I'm going to talk about the tools of the trade, the PPI test, endoscopy with biopsies, and this is my biggest conflict because I'm an endoscopist. The ambulatory reflux monitoring, this is the gold standard test, which is either pH testing or the impedance pH testing, high-resolution manometry. And then I'm going to talk a little bit about the new kid in the block, the what I call the electronic biopsy or mucosal impedance and admittance testing. So if we move forward from the Montreal definition and we look at the guideline, the next thing anybody who has reflux should undergo this PPI test, which everybody should be started on a PPI, and if they respond, we probably have our diagnosis. And actually, if you look at the guidelines say that if you respond to PPI, you don't need any further testing. Now, and we have done and seen a lot of work done in PPI non-responders. Let's look at PPI responders. So this is a study, and there are multiple studies, where they took 312 consecutive patients, negative endoscopy, typical reflux symptoms, and they actually objectively measured their symptom response, which we never do in practice, yet we use these symptom response to guide our therapy. And they divided them into non-responders, which is less than 50% respond on the GIS or VAS score, 50 to 75%, and then greater than 75% response. And this is what we see. I'm going to focus on PPI responders. About 20% of PPI responders, which objectively were showing 75% or more response, do not have acid reflux. And about half the patients that respond to PPI do not have an indication that require lifelong acid suppression therapy. And in real life, I can bet the middle group with the 50 to 75 response with our history and physical testing, we cannot differentiate them. So they probably are ending up in the PPI responder group. So almost half the patients that don't have an indication for long-term PPI therapy because of response to PPI are getting on lifelong PPI therapy. I'm going to move to endoscopy with biopsy, and this is from guidelines. Non-responder to PPI should be evaluated with an endoscopy, and we're really looking for GERD complication and potential alternative diagnosis. And we know it has a low sensitivity in diagnosis of GERD, specifically because most of the endoscopies are done on PPI. So the esophagitis is going to be healed. So it's really not a test to diagnose GERD, but to look for other conditions. And this is a statement straight from the Lyon consensus, which basically, simply put, there are probably two histopathologists who can read these biopsies accurately and reliably, and they probably don't agree with each other. So there's really no role in diagnosis of GERD or biopsies, definitely to rule out eosinophilic esophagitis. Now, let's move on to the real tests, which we usually don't do much. I'm going to sort of try to make a case that we should be doing more of these physiological testing. So this is the wireless pH testing, very commonly done in the US, not so much outside the US because of the cost. You can do prolonged pH testing. It's more physiological. Ideally, should be done off PPI medications. And then came the multi-channel intraluminal impedance pH testing, where there are multiple sensors, and they are measuring the intraluminal impedance, which is different than mucosal impedance. We'll talk about that. And simply put, and it's basically measuring flow and pH. And a flow going antigrade direction is normal. Anything that is going in the reverse direction is abnormal. And then based on the pH of that flow, we can further differentiate into acidic, weakly acidic, or non-acidic acid reflux. And this is from the Porter consensus. In essence, basically they're saying that most of the Bravo pH testing should be done off medication, and most of the impedance pH testing should be done on medications. And then there is a little square at the bottom which shows that if you did the mucosal impedance pH testing, that box can still have reflux, but if you haven't done formal reflux testing, I'm not sure how we can say that these patients, just because they had some response to acid or acid suppression, has acid reflux. This is high-resolution manometry, multiple sensors, then create a topographic map and give you a pretty nice profile of not only the esophageal body function, but the sphincter function. Currently in the practice, there are sort of limited use of manometry in GERD. One is for placement of your pH probe or catheters. And the surgeons use it for surgical planning, and probably it affects less than 10% of surgical planning of the patient, mainly ruling out eclasia or patient with severe esophageal motility disorders, especially body dysfunction. But there are some newer concepts that are coming with high-resolution manometry. One of them is that esophagogastric junction contractile integrity, which they use the EGJ-CI software and put it on the sphincter, and through inspiratory cycle, they do this measurement of the sphincter pressure. And that may be a more accurate measurement of the sphincter function. And then there's some other concept like multiple rapid swallow to look at reserve function, and Prakash tells me that patients that have can create a strong contraction after multiple rapid swallow will do good with an anti-reflux procedure. There is also better definition of the EG junction morphology with high-resolution manometry. This was in the Lyon consensus that they proposed this EG junction classification. Type 1, when there is no separation of the LES from the crural diaphragm, so there's no hernia. Type 2, when there's less than 2 centimeters separation. And then type 3, if there's more than 3 centimeters separation between the crural diaphragm and the LES. And then based on where the respiratory inversion point is, you are differentiated into type 3A or type 3B. Type 3A, the the rip is at the crural diaphragm, and these patients have high reflux. If your inversion pressure is at the LES, these patients don't have that much reflux. And probably this is an article from Sumit who forces me to read all his papers, that there may be a peritoneal pocket around the LES and the intra-abdominal pressures are being transmitted to LES, even if LES sits in the chest, and it's augmenting the LES, and that's why you're not seeing reflux. We briefly heard about esophageal shortening, and Ravi basically talked about the longitudinal muscles. And there's another paper I was forced to read from Sumit where he took prospectively done manometries in pHs, and he saw that there are certain people that when they had, during the swallow, the crural diaphragm and the LES did not separate, and there was another group of people where the crural diaphragm or the LES separated out. And in the people where during a swallow there was a separation, they actually, when they looked at their pH, they were more refluxers than not. And then the question is that, is this the mechanism where we talked a little bit about TLESR, and we know the esophageal foreshortening during a TLESR is more associated with a reflux event, and if there's no esophageal foreshortening, you don't see reflux events. So could this be a surrogate marker for TLESRs that cause reflux? Now, why is this important? You know, I think it's not going to change how I practice today, but I think this is an important area of reflux because we need better segmentation of GERD patients. You know, we basically, before all these different therapies came in, they were either a PPI patient or they were a Nissen fundoplication patient, and 20% of the population cannot be just treated with two therapies. So I'm hoping that the work being done out here will allow for better segmentation of these patients and then better patient selection and better patient outcomes with all these anti-reflux therapies. This is just a question, so how do we interpret these tests? Really, if you look at the endoscopy and the pH impedance testing are the two tests that can conclusively diagnose acid reflux, so LA grade CD, long segment Barrett's esophagus, esophageal stricture endoscopy will be a conclusive evidence of acid reflux, or esophageal acid exposure greater than 6%. Only pH or pH impedance can conclusively rule out acid reflux, and everything then falls in the middle. Just a slide on extraesophageal reflux disease, common problem. We don't have good tests. There's pharyngeal pH testing, but the data suggests that this is not accurate, and we need better testing to be able to diagnose these patients. Now, quickly moving to mucosal impedance. So this is different than intraluminal impedance. So when the impedance probe was placed in the esophagus, and while I was measuring intraluminal impedance, they were also measuring mucosal impedance. This is when the current is flowing through the mucosa and not testing the impedance of the luminal content. And what was seen is the patient with reflux disease have lower mucosal impedance. So that led to development of, my monitor is flickering, but to this endoscopic pH probe that can be passed through the endoscopy, placed on the mucosa, and we can directly measure mucosal impedance during an endoscopy test. And that has then led to development of a balloon-based impedance testing that overcomes the issues related to contact. So, you know, if the probe is lying, it could have differing or weighting contact, or if you put it through endoscope, contact could be issues, but if you have a balloon-based catheter that you can inflate in the esophagus, then you can measure impedance and the contact will be pretty good. And here is the data on mucosal impedance, and it looks pretty promising. And what we see is that when there's inflammation in the esophagus and edema, the impedance or the resistance to the flow of the current in the mucosa goes down. So if you look at erosive esophagitis or gastroesophageal reflux disease, the impedance is low in the distal esophagus, and as we move up, the impedance rises. While we look at eosinophilic esophagitis, it has low impedance throughout the esophagus. So that can differentiate eosinophilic esophagitis from reflux disease by mucosal impedance testing. And you can also look at response to PPI therapy. So once patients are given therapy, either anti-reflux surgery or PPI, their mucosal impedance improves, and we can differentiate responders from non-responders using mucosal impedance. If you look at test characteristic, and there are multiple publications on that, it got actually pretty good characteristic, almost coming close to the wireless pH testing, about 75% sensitivity and almost 95% specificity in diagnosis of erosive esophagitis. Here's another new kid on the block, mucosal admittance. This is coming from the Japanese. It's been commonly used in the dermatology world. Admittance is opposite of impedance. So there is an electrode sitting on the skin, and then it sends two different frequency, a low frequency and a high frequency current to your body. And then you have a catheter on the endoscope that is measuring the current flow. And the low frequency current goes to the extracellular fluid, while the high frequency goes to intracellular fluid. And your admittance goes up if there's inflammation. So that's what you're measuring. And there are studies with the test characteristics which are very promising. And finally, we talk a lot about diagnosing reflux patients, but there's very little focus on following these patients. And there's a huge impetus. Reflux is a chronic disease. If once you give somebody a diagnosis, he's going to live for the rest of their life with this disease. And we need better measures of following this patient longitudinally over time. And I don't think history and physical is good enough to follow these patients. And we need some objective patient-reported outcomes in not just GERD, but all chronic diseases. And hopefully, the mobile health tools and EHR can help us better use and better follow our patients over time to treat these patients. So my parting thoughts, the first sort of is a question that we demand conclusive evidence of pathological reflux before committing a patient to long-term, which is lifelong PPI therapy. Because right now, if they respond, they're on PPI for the rest of life. I think we should use objective, validated, patient-reported outcome to follow GERD patients because it's a chronic disease. It's a chronic debilitating disease. And I hope and pray the electronic biopsies will deliver on its promise because we really do need point-of-care testing for esophageal diseases, which can be done at the time of endoscopy. Thank you.